rains are about to come and we will be flooded. All of the country will have innumerable infectious diseases and tropical diseases. And to be well versed with it, under the leadership of Dr. Manak, Indore City branch of RSACP has done a commendable job. My best wishes for the best results of this webinar. Thank you. Please go ahead.
Thank you so much, sir, for these encouraging words. Respected Dr. Indrani Hemant Kumar, Madam, our President, we are pleased to request a few words from you.
Respected members, as Dr. Tejpal said, Indore is really doing a fantastic job, and within a short span, today they are projecting such an important topic on infectious diseases. And we all know that the burden of infectious diseases and tropical diseases is going to go high up in the next few months because of the rain and everything. And this topic stands on forefront, and in fact, what was neglected for the last so many years, infectious diseases and tropical diseases have taken a forefront in the last 2 years with COVID and other things. And as Sir said, it's taken a front line today, and I'll be eagerly waiting to know about the management and the ICU and other things, which is the topic for today for today's evening. And thank you very much for giving me an opportunity to meet all of you. Thank you very much. Long live RSACP. And Dr. Tejpal sir, your blessings as always is needed.
Always there. My pleasure and my honor to be a part of this group. Thank you.
Pleasure and my honor.
Thank you so much, Madam, for the encouraging words. And now I would request respected Dr. Naveen Malhotra sir to say a few words.
Thank you, Mayank, and heartiest congratulations to you and your team at Indore. And as our previous speakers have highlighted, the topic is important, but I must say the speakers and the chairperson were excellent. Dr. Manshu Diwan from Fidabad, Dr. Niklesh Jain from Indore, and Dr. Ashish Dang, alumni of PJMS Rohtak now at Delhi, and Dr. Smidua at Faridabad, Dr. Hina Chanwal from Ahmedabad, and very respected Dr. Meenu Chadda from Indore itself. I'm very sure all the delegates will have a very fruitful time and let the academics flow.
Thank you so much, sir. And just requesting for right. So RSACP Academic Webinar Series 2022, Infectious Diseases in the ICU. And let me introduce to the first chairperson of today's webinar, Dr. Simri Dua. She is an MD in anesthesiology, and she is Senior Consultant Anesthesiology and Critical Care Physician at Metro Heart Institute and Multi-Speciality Hospital, Faridabad. She is having tremendous experience in anesthesia, critical care, and pain management. Welcome on board, Dr. Simri Dua, madam. May we please hear from you a little bit? Madam, please unmute yourself. Madam, please unmute yourself. Madam, please unmute yourself. Madam, now you can speak. It's okay. Please unmute. It's okay. It's okay.
Mayank, you're the admin, so maybe you can unmute her from your end.
Then you are also muted.
I'll do that, sir. I'll do that, sir. Just a minute.
Hello.
I'll do that, sir. Yes.
Hello.
Yes, ma'am, you are audible.
Hello.
Yes. Madam, you are audible. Yes, ma'am, you are audible.
Go ahead. Go ahead.
Go ahead. You know?
Madam, you are audible.
Okay. Thanks a lot, sir. Go ahead. Okay, sir. Thank you everyone for making me part of this wonderful webinar. This is going to be a wonderful event, I believe, and all are very good, very renowned speakers. I would like to hear from everyone. Hello? Am I
Sir.
audible?
Yes, ma'am, please go ahead.
Yes, absolutely.
Hello?
Yes, ma'am, please go ahead. Please go ahead.
Hello?
Yes, ma'am, please go ahead.
Okay. I
Madam,
welcome all the
Madam, you
speakers
can-
and renowned teachers and guides.
Right. Thank you. Thank you, ma'am.
Hello?
Yes, ma'am. I'll introduce the next chairperson, ma'am. Yes, ma'am. I'll introduce the next chairperson, ma'am.
Okay.
Mayank, there is a lot of echo that is happening.
It will resolve in a while, sir.
Oh, there is an echo actually when I was talking.
It will resolve in a while,
I
sir.
was getting so distracted with the echo.
Yeah, it will resolve in a while.
There is an echo. Yes.
Right.
So
It
we
will
need
resolve in a
to
while.
we need to mute everyone other than the speaker.
Yeah, I think so.
To settle.
I've already muted everyone, sir.
Yeah. It should not distract the speaker. I'm worried about that. That's the only thing.
It won't. It won't. I think now it is okay. Now let me introduce you to the next speaker, next chairperson, Dr. Ashish Dancer. He is a consultant anesthesiology and critical care at NDMC Medical College and Hindurao Hospital, in charge of BLS and ACLS, trained more than 1,000 healthcare workers, and guide and co-guide to extremely good DNB students, many publications in various journals, and distinguished services in anesthesiology award for ISA 2018. He has conducted huge workshops on airways, and he is an instructor with AH accredited BLS and ACLS courses. His areas of interest are airway management, teaching, and training. Welcome on board, Dr. Ashish Dancer, and let me request you to please also introduce our first speaker, Dr. Deva. Thank you so much, sir.
Thank you, Dr. Mayan. Thanks once again, organizers, my seniors, to make me a part of this academic extravaganza. It's a very important topic, as all of you know that the rains are approaching, and our ICUs will be flooded with the patients suffering from dengue and malaria. So this is a very pertinent topic. I must congratulate the organizing committee. So our speaker for today is Dr. Himanshu Diwan. Dr. Himanshu is Associate Director and Head, Department of Critical Care Medicine, ORG Super Specialty Hospital, Maringo, Asia Healthcare, India. He has many feathers in his cap. A few of them are his Fellowship Intensive Care Medicine from UK. He is a Fellow of Indian Fellowship Critical Care Medicine. He is DNP in Internal Medicine, and his area of interest are sepsis resuscitation protocols and infection control in ICU. I welcome Dr. Diwan to speak on the topic of critical care for tropical diseases. Welcome, Dr. Diwan.
Dr. Diwan, you can share your screen now.
Yeah, sure, I'll do that. So, good evening to everyone, and I'm very thankful for the organizers to give me this opportunity to share something that is very close to all of us in intensive care unit. Our tropical diseases in ICU is a very pertinent topic for the time because we are in June and probably in a month or so, we'll see a lot of these. Particularly the last 2 years, we have seen more of COVID. And as we understand by the microbiology of it, as one viral disease dominates, the others actually go down. So the last 2 years, we did not see much of tropical diseases as we normally do these times. And again, I would like to say that in this topic, I have tried to reflect my own journey from being a physician to a critical specialist. As a physician, my understanding of tropical diseases was more limited to these hard boxes of, let's say, the case of malaria or a case of dengue, and understanding that these are possibly, different apart from each other diseases with very little degree of overlap. And as I progressed from a physician to being an intensivist, I realized that there's a considerable degree of overlap between these individual diseases. So by the time somebody who has a fever for a few days and he becomes sick enough to land up in an intensive care unit, they normally don't present as a single disease. They normally present as multi-organ dysfunctions. And it is very difficult at times, purely on the basis of history or examination or even lab investigations, to differentiate one of these tropical infections from the other. And a very difficult task is to differentiate the tropical infections from a simple bacterial infection that has presented to ICU and made a patient sick. So, taking this forward, in the next 20-22 minutes, I would discuss with you a couple of things. One would be our epidemiological evidence of what we see in our ICUs when it comes to tropical diseases. Then we'll have a few cases to understand what we are talking as a syndromic approach. And lastly, I would like to take you through the algorithmic approach to tropical diseases as a syndrome. So, taking this forward, when the monsoons hit us, this is what a Karan Johar movie tells us, that you're so happy, rain has come and you feel like dancing. But for a doctor, the facts are quite different. This is what my life is, and this is what I feel. And from 9 to 5, this is what I see. And when we go home, this is what we face. And as Vishal is in traffic right now, and this picture is 3 years old from Gurgaon, so this is what we normally see when we go home after hospital. So it's an extremely difficult time for us. And when it comes to media, this is how they bash us, that people are not getting beds, beds are full, people aren't being taken care of. So just to hammer the point that tropical infections suddenly become a surge and they overwhelm our critical care capacity of beds. So you see dropping in intensive care units a lot of dengue, a lot of malaria, and other infections like leptospirosis, scrub typhus, chikungunya, just to name the few important ones. And the biggest task, as I said, is to differentiate these diseases from run-of-the-mill bacterial sepsis. Now, it is very odd to know that till 2014 or 2012, we had very little epidemiological data from India to let us know that what we actually see in ICUs when it comes to tropical diseases. So from this study done by Dr. Sunil Singhi and group, they try to tell us a few very, very important epidemiological points when it comes to tropical diseases. So one, the tropical diseases, as we understand, they are a monsoon disease. So as you can see, the disease start rising in July. They reach a peak somewhere in October and September. But the important thing to see here is that even when the rainy season is off and temperature becomes much colder, we continue to see tropical diseases. So for us, if you look at the data, this is not just a tropical monsoon-related disease, it's a year-round thing which is happening. Only the thing is the numbers are different. You get higher numbers around monsoon and you get lesser numbers in the winter seasons. So a tropical disease would be differential in all patients presenting with fever and multi-organ at all times. What are the common presentations of these tropical fevers? They normally tend to present more commonly as fever with thrombocytopenia. Less often you will see respiratory failure, renal failure, encephalopathy, jaundice, and around 20% of the patients you will see multi-organ failure within the first few days of the patient being febrile. Now, this is a very important thing for us, that when you're looking at tropical fevers, what is more common? So in this study done around 2014, and data was collected in 2014 to 15, they saw that the maximum of these fevers turn out to be dengue. Out of them, almost 1/5 of total fevers turn out to be dengue, followed very closely by scrub typhus. Now that was odd, because what we felt is scrub typhus is an uncommon diagnosis limited to a few geographical areas. That doesn't seem to be the case. And if I bring your attention to the last part of the slide, in around 20% of the patients, 1/5 of the patients, even after extensive investigations, you are unable to reach a diagnosis. And then you have to approach them in an algorithmic fashion. Now, looking at this study, they gave us a few important tips about how do you predict the outcome of a patient who's present to you in ICU. The SOFA score on presentation is one of the most important factors regarding the survival or non-survival of the patient. His need for ventilation with the first few of the illness and his presentation being a multi-organ dysfunction are also associated with a poorer outcome and a higher mortality. Now, as a physician, this is how I would like to present tropical infections as malaria, dengue, leptospirosis, scrub typhus, or enteric fever. But then this changes the moment I become an intensivist, because these are not mutually exclusive distinct diseases. There's a considerable degree of overlap between the tropical illnesses. So a single illness can present in several forms, and several illnesses can have a similar presentation. So now I would like to discuss the same diseases like this. And patient presenting with acute undifferentiated fever, a patient presenting with fever with rash or thrombocytopenia, fever with respiratory failure, fever with acute encephalitic syndrome, or a patient presenting with a short febrile illness going into multi-organ dysfunction. So this is how we're supposed to approach a tropical illness in an intensive care unit. Just to take this point forward, I have a few cases, and this was clarify more in what I'm trying to say. So this is for all of you just to see, and let's see if we are able to diagnose these patients. This is a patient we got around 4 years back in our ICU, a 33-year-old female who's 33 weeks pregnant, gravida 2, paraven live 1. She was having fever 5 days along with vague systemic symptoms like nausea, lethargy, decreased appetite, headache. And she was afebrile for 1 day prior to coming to us. She was admitted for 24 hours at previous hospital, where her vitals were a heart rate of 92, a decent blood pressure 100/70, and saturating 94% at room air, slightly hypoxic. Her blood counts at the previous hospital showed nothing great, marked some anemia, 4.4600 TLC, slightly low side platelet, a decent cognition profile, a decent renal functions, slight elevation in the SGOT-PT, malaria rapid and smear were negative, dengue NS1 and IgM were negative, and urine was not revealing of any significant UTI. And the ultrasound done at the hospital, obstetric ultrasound, showed a live fetus with no other abnormalities. So this was 1 day investigations prior to coming to us. So she came to us, and the reason for referral was an obstetric indication that we could not, the gynecologist could not see fetal movement for the past 24 hours. The patient is getting increasingly drowsy, breathless, hypotensive, and non-responsive to fluid boluses. In the emergency, we found the patient to be significantly tachypneic and hypoxic, tachycardic, and now markedly hypotensive. The blood gas showed that she's got a metabolic acidosis with high lactates of 5.6. Our initial response was give a fluid bolus, add vasopressors, targeting a MAP, take some cultures, and the first dose of antibiotic was given. Coming to ICU, of course, she was deteriorating. We intubated and ventilated her, put her on vasopressors, and our first laboratory examination revealed that the leukopenia and the thrombocytopenia has worsened. So has the renal function with a rise in creatinine to 1.8 and a marked elevation in liver enzymes going from 80 value to 3000 and 2500. With marked elevation of population in the form of INR, the procalcitonin was 1.4, slightly elevated, ammonia 154, and this is arterial ammonia, and the X-ray showed bilateral fluid effusion. Ultrasound revealed there's a hepatomegaly with gallbladder edema of 6 millimeters. Now, with this, I would just like to take it to the audience that what we could understand is this becomes a case of acute fulminant hepatic failure. Now, the causes could be pregnancy related or pregnancy associated. Anybody wants to take a, try to diagnose based on the information I have given till now regarding the diagnosis when it comes to tropical?
Was it dengue or dengue?
So it could be. So any specific points you think it is dengue? Anything specific in investigations that you think it points more towards dengue?
46,000.
Platelet count is low. Yes.
Yeah.
Absolutely.
There is bilateral pleural effusion. INR is on the higher side. LFT has suddenly risen.
Correct.
So we need to evaluate upon the
IgG has been done.
So at the previous hospital, no, they did not do it IgG for an acute infection in IgM and NS1, and both were negative a day prior to coming to hospital.
So this is was negative.
Yeah, day 5 of illness, NS1
this
and
IgA.
Day
5 of illness.
Correct.
This goes towards dengue.
Yes. So you have the right diagnosis, and I'll just take it forward. Now we repeated the malaria is negative, leptospira negative, dengue IgM is positive, and other tropical investigation, including cultures, are negative. And our final diagnosis was an acute fulminant hepatic failure in pregnancy precipitated by dengue. So I think you got a few things absolutely right on. The most prominent thing in this investigations are actually two. One is the marked thrombocytopenia with marked hepatic dysfunction. So if I was to put my money on the differentials, my first differential would be dengue, because such a marked thrombocytopenia normally doesn't occur in other illnesses, one. And two, you have a marked hepatic dysfunction, and in pregnancy, dengue is known to precipitate acute fulminant hepatic failure. This is more common in people who are pregnant, especially in the third or the first trimester. So, sir, your diagnosis is absolutely correct. And this case highlights how difficult it is to differentiate one from the other by actually picking up these subtle findings. Now, a few points about dengue treatment. One, always avoid excessive fluid resuscitation. Don't fluid overload the patient, because as you picked up, there's bilateral fluid effusion. That's an evidence of capillary leak. The moment fluid effusion comes in, and the more fluid you resuscitate, the worse would be your third spacing. Avoid colloids. Early use of vasopressors, less on fluids, more on vasopressors should be the way that you get a map up. Avoid FFP in all situations. Until unless you are going to operate or the patient is bleeding to death, have a very, very high threshold to give plasma, because the moment you push in FFP, the patient's lung will just go off. Aware of the false negative serology. Day 5 to day 7 is a period where you might get both NS1 and IgM negative. Aware of co-infections. Sorry, I can't get that. I didn't get that. Did somebody ask a question?
Anybody ask a question? If there is any doubt, please put it in the chat box.
Okay. So always be aware that dengue could always present as a co-infection with, let's say, viral hepatitis in this case, or malaria. So even if the patient, you got a diagnosis and the patient is not getting better, always look for a co-infection, which may be a bacterial infection. And be aware of the odd presentations of dengue, like in our patient. Second case, again, a case we saw maybe 2.5, 3 years back, pre-COVID. 52-year-old male. He was febrile, 103 for almost 6 days continuously. complaining of severe body aches, myalgia, bilateral calf pain. So he came to us, he's alert, he's tachycardic, normal blood pressure, febrile, and slightly hypoxic. When you look at his examination, he's ectric, he's got some conjunctival suffusion like this. This is the picture. Bloodshot conjunctiva, palpable conjunctiva. Bilateral calf are severely tender, and the lab scents on admission are this. So you got a decent hemoglobin, a decent TLC, low platelets, creatinine is high, your hepatic dysfunction is there with the form of direct bilirubinemia, and a OT, a PT more than OT elevation, a high CPK levels, X-ray and ultrasound and bilateral lower limb venous Doppler because he had severe calf tenderness were non-revealing. His malaria and dengue were negative, and we started him empirically on ceftriaxone with doxycycline. He got worse in the high dependency unit, transferred to the ICU. This is the X-ray, what it looks like on day 2. Marked worsening from a day 1 X-ray. You could appreciate bilateral non-homogeneous opacity, more on the peripheries and the bases, and he developed worsening of renal, hepatic, and hematological parameters. Day 3, this is the X-ray, marked worsening of hypoxia, marked worsening of X-ray. He had hemoptysis, and we intubated him, and with the current treatment of ceftriaxone and doxycycline, is still getting to get worse. And we did not understand why he's getting worse. So we put in a bronchoscope, did a lavage, and we found that this person has pulmonary hemorrhage. So 3-file test was positive for increasing blood in the third vial. So at this point, these are differential diagnoses. Could it be a bacterial sepsis we have inadequately covered? Could it be malaria? Could it be leptospira? Could it be scrub typhus, or presentation of dengue, or a viral pneumonia? Anybody wants to take a guess at what it is? Day 6 of illness, presenting with multi-organ, and the chest is going off into frank ARDS with superimposed pulmonary hemorrhage. Could it be? Say that again, sir.
H1N1?
H1N1. It could be a viral pneumonia, but the odd thing is he did not have any URI symptoms prior to his the chest going off. So little odd.
Right.
Your creatinine is also high.
Yes,
Leptospira
2.3.
also? Muscle pain is there now.
Calf pain is there.
Calf pain, severe muscle pain, high CPKs, a very high bilirubin and going off of SGOTPT, the lung being involved. So I like to put my money here on leptospirosis and scrub typhus and maybe malaria. Dengue normally doesn't present like this. So I have a few differentials, and what we found this out to be was leptospirosis, as you rightly picked up. So just to hammer the point that these patients present with a muddle of findings, and by 1 or 2 patterns you pick up that this was sequence. He had fever, no URI, nothing. Then he on day 6, day 7 got worse. He had a major worsening of his chest. Major worsening of chest reveals 2 things. Either it is leptospirosis or scrub, right? And if for the isolated lung finding, I would have made a diagnosis of H1N. Now leptospirosis is increasingly common in India in all parts because we increasingly started to recognize it. The organism being Leptospira interrogans, and the source of infection is contaminated water getting in touch with skin and doesn't seem to be a biphasic illness. A lot of times is present as a uniphasic illness, and you don't get that gap from a normal fever to Weil's disease. And by day 7 and 8, the patient is getting worse. The diagnosis is basically based on IgM, ELISA, and MAT, a lesser severe form of leptospira with no multi-organ, just fever, no lung involvement. You can treat with oral doxycycline. Otherwise, the drug of choice would be C-penicillin or third generation cephalosporins. Penicillins are not easily available. Now, a few points about the management of all tropical illness. As in critical care, everything starts with ABC. And regarding airway, have a very low threshold to intubate patients who are having respiratory failure because they tend to get very worse very fast. When it comes to breathing, you are okay to use non-invasive ventilation for a short while, but keeping your intubation things ready. Do not prolong the NIV for long. The patient normally in moderate to severe illness would not respond to non-invasive ventilation. When it comes to circulation, in all tropical illness, we have a tendency of absolutely avoiding all colloids and being very limited in our resuscitation with crystalloids as well. It is important to identify if there's any localized foci of infection, because at times what you're thinking is tropical may turn out to be UTI or a simple pneumonia. So always keep a lookout for any bacterial source of worsening. Take a culture, do a procalcitonin, and if you're not understanding what it is, the tests are not coming positive, always use appropriate empirical antibiotics. A lot of people use procalcitonin as a single test at the presentation to differentiate a bacterial from a tropical infections. So this meta-analysis and many such meta-analysis have proven that procalcitonin should not, cannot, will not help you in differentiating a tropical or a viral source from a pure bacterial source. Why? Because in a lot of conditions, procal seems to be negative even in bacterial infections, and it can be positive in tropical infection, especially in malaria, where you can have a very high procalcitonin. Procal rises spuriously in patients with renal dysfunction, with whatever is the cause of renal dysfunction. So you cannot use procalcitonin as a differentiating feature between bacterial and non-bacterial infections. Very, very important point to remember. Very important to see the patient en bloc, head to toe, detailed examination. Look for rashes. Look for if you find an eschar of scrub. We found in one patient eschar inside the auditory meatus, in one patient behind the ear, in the groin, under the scrotum. So the patient needs to be examined head to toe after removing the clothes. Very, very important. As in all patients, you would do these routine investigations. A few important points here to mention are that in case you do want to you want to exclude malaria, you are okay to use a rapid test, but that rapid test has to be a standardized rapid test kit, which has got an HRP LDH antigen on it, and 2 antigen negatives are required to say it is not malaria, and 3 smears negative are required to say there's no malaria. And in my case, even if I have 2 antigens and 3 smears negative, if I have a high degree of suspicion of malaria, I may still decide to continue with artesunate. Now, just a few points here. After you've done your initial evaluation, history taking, physical examination, your initial lab reports, you do a series of rapid diagnosis tests. If the rapid diagnosis tests are revealing of the diagnosis, so you have malaria, treat as malaria. If you have dengue, treat as dengue. If you have rapid typhoid positive, treat as typhoid. Just be wary that the rapid typhoid test is quite a useless test. The IgM it picks up is positive in a lot of patients who are non-typhoid. Why? Because it tends to pick up IgG along with IgM spuriously. In case you do not get any rapid test positive, then you have a blanket empirical coverage to cover all possible tropical infections, including a few bacterial infections, till the time you are able to get a diagnosis. So till the time you're doing the testing and diagnosis, start covering your patient with the 3rd generation cephalosporin along with doxycycline. And if you have a high degree of suspicion of malaria, use artesunate along with it in the appropriate weight-based doses. In pregnant ladies and patients where you cannot use doxycycline, especially like in children, you can replace doxycycline with azithromycin and continue with the investigations. My points from this presentation were 4. 1, in all these patients who have come to you with a brief febrile history going into organ dysfunctions, normally the pattern gives you clarity. Somebody who had fever, let's say for a 4 or 5 days period, and started to go off in the liver and other things are lagging, you think of viral hepatitis, right? If you have a patient with fever and the first organ dysfunction you pick up is thrombocytopenia, followed by others, think as dengue. If you have a patient, typically nothing is suggesting, no examination, purely undifferentiated fevers, even the investigations are going off simultaneously bad, think number one as malaria and number two maybe enteric. Patient who's come to you with a travel history, possibly an ESHCA, he's got fever and the lung starts going off. Your number one diagnosis here should be scrub typhus. So in all such situations, never let go your guard of missing and bacterial infections. So always have a high degree of bacterial infections. Do your cultures, give your appropriate empirical antibiotics, but do not rely on procalcitonin to differentiate or exclude bacterial infections. If you have a high degree of suspicion for one test, like in first case, we thought very strongly of dengue, we repeated dengue, so the dengue had been done a day before. And in case of malaria, we repeat malaria multiple times, right? And one more thing, as in intensive care, we work in groups, we have friends all over the town. So the moment illness starts coming in, so you start seeing dengue, your friend will let you know, I see 5 cases of dengue. You start getting H1N1, you talk to your friends, yes, they started getting H1N1. So likewise in COVID, you start getting COVID. So keep your social radar on mode to know what's happening around your hospital. This will help you diagnose better. Thank you so much for your patience.
Thank you so much, sir. It was a pretty nice talk and a very comprehensive talk. Pretty informative, sir, and presented in a very beautiful fashion. Thank you so much. Thank you so much, sir. Can you please stop sharing your screen, sir? It is a request.
Yeah, I do that.
The topic is open for discussion. Any questions and remarks from the chairpersons?
Many congratulations, Dr. Devan. Nicely covered. And, as Dr. Mayank has rightly said, in a very short time, you have covered, the basics of tropical disease and ICU care. And I must congratulate you. Very nicely spoken, Dr. Devan.
Thank you so much.
Madam Dua, any comments, madam? Please unmute yourself, ma'am. The topic is also open for discussion. Any questions? We can have a discussion right now. Dua ma'am, any comments? Please unmute yourself, ma'am. Please unmute yourself.
Am I audible?
Yes.
Am I audible?
Yes, ma'am.
Very, very nice explanation about all the tropical disease and how to differentiate between all the diseases. Very well explained in a very short time and with 2 case scenarios. Both were very good. How to differentiate between different diseases and how to proceed with when patient comes in emergency and in ICU, how to proceed and how to investigate. Very well explained. Really, really very nice talk.
Thank you, ma'am. Thank you so much.
Excellent presentation. It was a very good, the case-based, the whole thing was flowing so well and very well explained. And, having experienced of dengue in quite a severe form myself, I would say that, one has, I've also seen many pregnant ladies succumb to dengue and lepto and things like that, especially in Mumbai. With Mumbai rains, we have seen lots of pregnant ladies succumbing to these kind of illnesses. And for me, I remember way back about 4 years ago, having suffered dengue, the leaky capillaries is something which, which I suffered like anything. All my joints were swollen. There was, I had a kind of, what do you call, stiff neck and pleural effusion and, things like that. All these are typical presentation, not just for dengue, I suppose, even for other tropical illnesses.
See, the point you said, ma'am, very relevant. So when I'm training my DNB fellows, a few pointers towards dengue is one, do not treat them aggressively to make them worse. So only thing an intensivist can do to dengue is make it worse by giving him a lot of fluids and not taking out of the cardiomyopathy, unnecessarily giving him platelets. So we in our ICU have a very high threshold for giving platelets because the more platelets you give, the slower is the self recovery of the patient. So our threshold is not even 10,000. We just let go and wait. We keep our platelets steady. Do not unnecessarily give platelets. Fluids is very, very important. Do not overhydrate your patient. It will make the third spacing and the organ dysfunction. The third spacing is actually organ dysfunction. It makes it worse. And in a lot of patients, we are restrictive in your dengue management, in severe dengue. The patients tend to get better. So I normally, I joke that the patient survived in spite of us.
So then, so you don't even give platelets until you find clinical indications that you have to give, is it?
Absolutely, absolutely.
So
if you have to put a central line, let's say you have to do some surgery, or if the patient is bleeding. So for petechiae, if you got fresh petechiae, I would not even transfuse at 10,000. This has to be a significant bleed, not nasal income bleed. Because over the last 3-4 years, data has come out that so initially it was like 20,000, then it became 10,000. And even at 10,000, if you're restrictive in your platelet transfusions, you're okay. Because if those are minor bleeds, they'll get better. And if you see your patients, the nadir, the lowest point of platelet of 4,000, 5,000 stays for a few hours, 12 to 16 hours or a day, and it gets better. So, it doesn't stay that low for very long, and it gets better. The moment you put in platelets there, the recovery is slower. So he will be thrombocytopenic for 3 to 4 days.
what about steroids? I mean, do you give steroids at this point of time?
No, not at all. They're counterproductive.
You don't give steroids in any of them?
In dengue, in leptospira, yes, we use steroids. In let's say viral pneumonias, in patients like in pulmonary hemorrhage, we would use high dose steroids. But in routine run-of-the-mill dengue, hemorrhagic dengue, or I would not use steroids. Dengue shock, typically septic shock management steroids, I would use.
Sir, in scrub typhus, how do you proceed with the things like your management style in scrub typhus?
Scrub typhus is one of the trickiest of these buggers. So one, the moment you have a diagnosis and you get the doxy into his bloodstream, the X-ray just fizzles out. The pneumonia vanishes as if there was nothing. So it's the clinching of the diagnosis. Patient who's toxic, you give in doxy, 3 doses in, the toxicity goes off, the hypoxia gets better. That's how rapidly it responds.
Very close relative of mine suffered scrub typhus, and what you are saying is absolutely true.
Yeah. We would use scrub typhus steroids in patient who's getting rapidly worse and where we're unable to do a bronch. So we have a very low threshold for bronch. We do it ourselves. So if you are able to put the bronch in and you're able to document hemorrhage, it really helps. It really helps.
In dengue, sir, how will you manage, like, if the patient develops leaky capillaries and the fluid is in the, there is pleural effusion, there is ascites. So how you manage such patients?
So actually, if you ask me, there's not much to manage. You just have to give body time. So the leaky capillary stage will last between 3 to 5 days. Leaky capillary is not a big problem until it is refractory shock. So I would be heavy on my vasopressors to maintain a decent map. I'll be light on my fluids just to maintain enough perfusion and keep my lactates and tissue perfusion normal, lactate near normal. If you say something in particular about use of steroids, it's quite debatable. I think that's what you're asking about. I would be very restrictive in my use of steroids in dengue.
Okay, can I add to that discussion?
Yeah, please.
Please, sir. Please, sir.
See, what really happens is, I won't say that there's a blanket refusal from whatever experience I have of treating dengues. What we do is, in all these dengue patients, we get serum ferritin, LDH, and those levels done. And what really happens is that if in case you see a hyperferritinemia, which is more than 900, then what we do is actually we tend to use a dose of DEXA for the simple reason because there's a very high likelihood of these patients having a macrophage activation syndrome. If these patients, in these patients, if you allow macrophage activation syndrome to progress, then these patients land up with a very bad outcome. So that probably is the only indication wherein we are actually using steroids. But for that, you use a baseline ferritin and LDH levels to sort of tide over the initial things. If your ferritin levels are fine, then I don't see any indication to give steroids in any way whatsoever.
See, I actually agree completely with you. Just for the sake of the audience and the discussion being just the completion of discussion, HLH or any macrophage activation syndrome, HLH and mass is the papa and HLH is one of the babies it has. So this is a differential that you keep in a patient who came to you worse, got better, and for no reason got worse again.
And a lot of these patients are getting referred to you at different stages. So what really happens is that some of them may be coming early, some of them may be getting managed elsewhere and then coming to you late. So Absolutely. It's sort of a variable spectrum that comes.
Yeah. So just to complete a discussion and we discussed a classical presentation of HLH. We saw HLH in COVID as well. So we had patients, we did triglyceride, ferritin, D-dimers. So we were not understanding why these patients are getting worse on the end of second week. This guy's CTCSS is static. He tends to getting better. His hypoxia is better. And for no reason, he's getting worse. And the two patients we diagnosed HLH, there are two differentials there, especially in relation to COVID. One is the dysregulated immunity, which is specific to COVID, and other is HLH. And as you rightly mentioned, every intensivist should have HLH in the back of the mind because one of the treatable things that you have.
Thank you so much, sir. It was a great discussion. And with the now Dr. Vishal
Hi, Dr. Himanshu, I have one question for you. If you could.
I hope not a difficult one.
There's nothing difficult for you, dear. Crystalloids are the fruit of choice in dengue. And when do you contemplate using albumin in dengue?
Never.
In dengue shock syndrome, no role of albumin.
See, the thing is, I'll tell you how. Albumin is available in two formulations. One is the 5% albumin, one is the 20% albumin. So 20% albumin is a strict no. You cannot use 20% albumin because it is such a high oncotic osmolality, it will just go into lung and make it worse. 5% albumin is a resuscitation fluid. So if you're using 5% albumin for resuscitating a hypoalbuminic patient, even in a normal sepsis, which is indicated, hypoalbuminic septic shock, it's okay to use 5% albumin as a resuscitative fluid. Here in dengue, what happens is that you would get benefit. You use 5% albumin, you would get a better hemodynamics for the first 16 to 24 hours by the use of albumin. But because of leaky capillary, as the moment the albumin leaks out into the third space, it will make the organ dysfunction worse. So if possible, I would avoid any formulation of albumin in dengue. Until unless, one, if the patient is crashing, nothing is working.
Not responding to more crystalloids. And what is the dose of steroids you use? Is it 50 milligram hydrocortisone QID or you use methylprednisolone?
Is that for septic shock?
For dengue shock syndrome.
So it's the same dose. It be 200 to 300 milligrams. And we actually started using 200 milligrams as a continuous infusion.
Continuous infusion. Thank you very much. Thank you, Dr. Himanshu. Over to you, Dr. Mayank.
Over to you, sir. Welcome. Finally, you have reached home and after a drive and a small comment from you regarding the webinar.
Thank you very much. Good evening, all. Respected Dr. Tej K. Kaul, sir, Dr. Indrani ma'am, Dr. Naveen Malhotra, sir, and all the GC members. It has been pleasure seeing everybody here. And it was so warm to see Dr. Himanshu, Dr. Ashish, sir, Dr. Simi ma'am, Dr. Meenu Chadda ma'am, Dr. Niklesh Jain. And I welcome you all in this webinar series connected by RSACP. And I would also like to especially thank Dr. Naveen Malhotra, sir, and Dr. Sunil Sethi sir, and also also Sunil Chaubeji for providing us technical support for conducting this webinar live on the YouTube and CJ television. And thank you very much. I'm looking forward for the next topic, nosocomial infections. Over to you, Dr. Mayank.
Thank you so much, sir. Thank you so much. So moving on to the next chairperson, it is Dr. Hina Chagwal, madam. She is at this present moment the professor as well as the head of the Department of Anesthesia for GC SMCH, Ahmedabad and RC Ahmedabad, Gujarat. And her major achievements are she has been a secretary of ISA Ahmedabad City Branch from a period of 2017 to 2019. ISA Gujarat State Branch Treasurer from 2021 to 2024, has been a faculty and chairperson in various international, national and state conferences from 2013 till date. She has organized more than 10 BLS ACLS workshops till date and organizer of cadaveric and ultrasonography guided regional conference in December 2018, as well as perioperative ventilatory conference in August 2019. She has been a chief editor in the book named Essentials of COVID-19 for Anesthesiologists, published in June 21. Scientific secretary and playing a very pivotal role in the National Anesthesia Conference of ISACON 2021. And she deserves a real credit for that because that was a conference that deserved a credit after Corona. It was so well done. ISA Proficiency Award 2021, ISA Presidential Appreciation Award 2021, reviewer for Walter Kluwer since 2 years, editorial board member of Indian Journal of Anesthesia and Analgesia since 7 years. Welcome on board such a prestigious person, Dr. Hina Chagwal, and a few comments from you. Thank you.
Thank you.
Ma'am, please unmute yourself and a few comments.
Yeah, thank you, Mayank sir, for introducing me, and I am thankful to you and your entire team for making me a part of this wonderful webinar. Thank you, sir.
Moving to our next chairperson, respected Dr. Binu Chanda ma'am. She is the head of the department, my head of the department as senior anesthesiologist and pain physician at Convenient Hospital Limited Hospitals in Indore. And her major achievements are she has been a faculty speaker and tremendous academician in various national conferences of anesthesia since past 20 years. She is faculty speaker in National Pain Conferences past 15 years, presented a poster in the World Congress of Pain in Boston, which was well recognized on cleft lip and palate. She has been ex-president of MP State Chapter ISA. She was the chief scientific secretary for ISACON of 2012 in Indore, which was a major hit, and has number of publications to her credit. Welcome on board, madam. And I would also request you to please introduce our next speaker, Dr. Nikhilesh Jain.
Thank you so much, Mayank. The next speaker, Dr. Nikhilesh Jain. He is a dear friend of mine, and he is also in the same hospital. He is the director and operational head of Department of Critical Care Services at the CHL Hospital Indore. He is a physician intensivist with about 20 years of experience. He is DNB Medicine, MRCP from Ireland, IDCCN, FCCN, and FIECMO. His areas of interest are hemodynamic monitoring, ECMO, infectious disease and sepsis, critical care in ultrasound, and multi-organ transplant. He has over 65 national and international papers and reviewer for neurocritical and many other national and international journals. He is associated with Grotto and Soto Premier Organ Transplant Society of India. He is a teaching faculty in the FCCM Fellowship course in critical care, and he was the past secretary and president of the ISCCM Indore City branch. Now, he would be speaking on a very important topic of the ICU, that is nosocomial infection in the ICU, which is also known as the hospital-acquired infection. So this is basically the infection which occurs within 48 hours or more after hospital admission. And I think he is the one who's going to enlighten us more on this kind of infection, and also I think the ventilatory associated pneumonias which occur along with that. Welcome, Dr. Nikhilesh.
Thank you, ma'am. Thank you so much. At the outset, I'd like to thank Mayank and RSACP for giving me this opportunity to come on the forum. And actually, I took the liberty of, sort of cutting down the topic of nosocomial infections with a pure focus on nosocomial pneumonias, because it would have been very difficult in 30 minutes to, sort of cover everything and cover the finer nuances. Because each one of these topics is huge, whether I would like to do a CORTI, whether I would like to do a skin and superficial tissue infection, or whether I would like to do a nosocomial pneumonia. So I'm confining myself to nosocomial pneumonia for my talk. I would be sharing my screen now. This is it. Oh, right. This is visible, everyone?
Yes, sir, this is visible. Please go ahead, sir.
Okay, thank you. So basically, how to define it, there are a lot of related terms when we talk in terms of pneumonias, nosocomial pneumonias, hospital-acquired pneumonias, and other terms which have been floating around throughout the years. So when we talk in terms of nosocomial pneumonia is an acute infection of the pulmonary parenchyma, which is actually acquired in the hospital settings. And it encompasses two types of pneumonia. It could be a plain hospital-acquired pneumonia, and it could be a ventilator-associated pneumonia. If we talk about hospital-acquired pneumonia, it is pneumonia acquired more than or equal to 48 hours after an hospital admission. And again, it includes both hospital-associated pneumonia and ventilator-associated pneumonia. When we talk in terms of VAP or ventilator-associated pneumonia, it is the pneumonia which is acquired more than or equal to 48 hours after an endotracheal intubation. Now, this translates to 48 hours. This does not translate to 2 full days, as I would come later into the classification. And then there was another term which was sort of, used in between, something called as healthcare associated pneumonia. So that is now, I use the word retired term because it is no longer considered relevant and it is no longer used in big way. It used to refer to pneumonia which was acquired in healthcare facilities, such as nursing homes or hemodialysis centers, or after a recent hospitalization. So some more important terms which become relevant when we talk in terms of therapeutics. So what is MDR? It refers to non-susceptibility of at least one agent in 3 different antimicrobial classes. XDR is extensively drug-resistant bug, which refers to non-susceptibility to at least one agent in all but 2 antimicrobial classes. And there's a pan-drug resistant or PDR, which refers to non-susceptibility of all antimicrobial agents that can be used for treatment. So effectively, PDR would be something in which I can tell the patient to go home because I've got nothing left with which I can treat you. Now, why should we talk about this at all? It's a very common and morbid hospital-acquired infection, and highest risk for hospital-acquired pneumonia is in patients who are on mechanical ventilation. That is what we refer to as a ventilator-associated pneumonia or a VAP. Now, we all know as NABH has come in and all the people are required to audit their data and are required to put it forward. There's an NHSN definition of VAP, which includes qualitative criteria. The qualitative criteria in NHSN definition include increased secretions or worsening oxygenation. But it is unclear whether reported decrease in VAP incidence represents a true decline or it is reflecting the stricter application of these subjective criteria whenever we sit down and apply these criteria in terms of defining a new onset ventilator-associated pneumonia. Obviously, it is associated with long hospital stays and significant costs, which in Indian setting become very significant because most of the expenses, even now in our country, are out of the pocket. So these are the common risk factors for MDR pathogens, huge list. IV antibiotic use within previous 90 days, septic shock at the time of VAP, ARDS which precedes VAP, more than or equal to 5 days of hospitalization prior to occurrence of VAP, and patient who's on renal replacement therapy prior to onset of VAP. Then you have separate risk factors for MDR, Pseudomonas, and other gram-negative bacilli. Probably gram-negative bacilli I would like to put my more focus upon because in terms of resistant infections, MRSA has not been that significant a problem as has been MDR, Pseudomonas, and other gram-negative bacilli. Probably, I'm not aware, different ICUs have different flora and fauna, but for my ICU, it is Klebsiella which I deal with. And from whatever my colleagues talk about, probably Klebsiella is the bug to watch out for in most of the ICUs in the country. So risk factors would be treatment in an ICU in which more than 10% of gram-negative isolates are resistant to an agent being considered for monotherapy, and treatment in an ICU in which local antimicrobial susceptibility rates are not known, or colonization with or prior isolation of MDI Pseudomonas or any other gram-negative bacilli. So when we talk in terms of specific factors, number or virulence of microorganisms entering the lower respiratory tract and the response of the host become an important factor. Primary route of infection remains the lungs, through which the microaspiration of organisms happens, specifically those organisms which colonize the oropharyngeal tract. Now, keep this in mind, when we talk in terms of aspiration, there's very well documented data that approximately 45%, the figure is that high, of healthy subjects, they actually aspirate during sleep. So whenever we're talking about severely ill patients, there's an even higher proportion which actually keeps on aspirating routinely. And if you have an endotracheal tube, it actually facilitates aspiration of oropharyngeal secretions and bacteria into the lungs. There are certain other factors: colonization with microorganisms which are acquired from the hospital environment, direct contact with environmental reservoirs, including respiratory devices and contaminated water reservoirs. In normal course, our upper GIT or stomach is usually sterile because the pH is acidic. Now, what really happens is, in a lot of ICU patients, we tend to hit them with PPIs, proton pump inhibitors, because of various reasons. Sometimes it may be a part of routine prescriptions. Sometimes it may be a part of prophylactic prescriptions. Sometimes it may be a part of a therapeutic prescription, either due to illness, medications, or enteric feedings. And that's when alterations in gastric pH happen, which make the patient more susceptible to acquiring ventilator-associated pneumonia. So how do they present? You've got common symptoms in the form of dyspnea. Now, please remember that very few patients will actually complain of dyspnea because most of these patients are non-verbal as they are on mechanical ventilator. Signs, yes, definitely yes. Fever, tachypnea, increase of purulent secretions, sometimes hemoptysis, bronchi crackles, decreased air entry, manifesting decreased breath sounds, bronchospasm. Then you can get problems with ventilator mechanics in terms of reduced tidal volumes and increasing inspiratory pressures. You can get lab findings in terms of ABG in the form of worsening hypoxia or PF ratios along with leukocytosis. And the most common thing, new or progressive infiltrate on chest radiograph, or if you are feeling, if you are able to get a CT done for these patients, CT comes into picture, which will be more definitive, obviously. Now, the most common investigations that these patients have at bedside would be a chest X-ray. So definitely, yes, you suspect a VAP, you get it done. Common radiographic abnormalities will include new alveolar infiltrates, air bronchograms, and saluting of adjacent solid organs. It is a good tool for determining severity of the disease, in the sense that by looking at the chest X-ray, you can pick out whether this is a multilobar involvement or a unilobar involvement, and at times you can identify complications such as pleural effusions and cavitation. But chest imaging abnormalities alone, please remember this, alone are insufficient to diagnose VAP, as findings are pretty non-specific. So then we come to other imaging modalities. What do we do? You've got a patient with a normal chest radiograph who has clinical symptoms of respiratory tract infection. You obviously need to go to any other imaging modality. CT sometimes can actually help you in terms of identifying a target lobe, which can be used subsequently for doing a bronchoscopy and sampling. Lung sonography is quite useful nowadays for ruling out pneumonia, but still, there are certain findings which are quite specific, and they are subpleural consolidations and dynamic air bronchograms, which I'm telling you, may support a diagnosis of VAP. So how to diagnose? It becomes difficult actually at the bedside because the clinical findings are pretty non-specific. And if you look at the different criteria, the clinical diagnosis is actually based on the new lung infiltrate plus the clinical evidence that infiltrate is of infectious origin, which can be seen in the form of new onset fever, purulent sputum, leukocytosis, and decline in oxygenation. Now, there are no individual signs or symptoms, nor any combination of the same, which are highly sensitive or specific for diagnosis. And if you talk about cultures of pulmonary secretions, now mind you, I put sputum here, sputum should not be actually put here. because most of the patients who come to me would have received some form of antibiotic. So sending sputum after receiving an antibiotic is of no use. You need to have a patient who's not received any antibiotic, and then you do a sputum, that is fine. Then ET aspirates and bronchoalveolar lavage, which are actually prone to false positives and false negatives. Nowadays, this is the new kid on the block, though pretty expensive as of now. Multiplex PCR assay, and there are a lot of labs which have come up which are doing these samples, and they have been approved for diagnosis in limited ways, specifically strep pneumonia and certain other pneumonias, wherein they are being used widely now. So to summarize, PAP is quite hard to diagnose. You need to have a surveillance definition as provided by the CDC and NHSN. I'll be coming to that. And you have to have a clinical definition for bedside use or studies, clinically pulmonary infection score in the form of CPIS. Very important, probably I'd rate that the highest, clinician instinct, with or without an invasive diagnostic approach. So still, it's a very, very clinical diagnosis. It's very much something that you diagnose at the bedside when you see a patient. And when you talk about surveillance definitions and clinical definitions, at times when you are, sort of sticking to the rules, it is not easily differentiable about which patients you consider as VAP and which you don't. So now when we talk in those terms, there are certain other terms which we need to know. There's something called as a ventilator-associated condition. This is as per the NHSN. So ventilator-associated condition, you've got a patient who's got a baseline stability, patient improves on ventilator, and which is defined by greater than or equal to 2 calendar days of stable or decreasing daily minimum FiO2 or PEEP values. Now remember that 2 calendar days could be a patient coming to you maybe in the evening, and your assessment maybe by yesterday evening, and your assessment by today evening. That itself would count as 2 calendar days. So the 48-hour criteria can be, sort of waived off in that sort of situation. After a period of stability or improvement on the ventilator, the patient has at least one of the following indicators of worsening oxygenation. You've got an increase in the daily minimum FiO2 of more than or equal to 0.2 over the daily minimum FiO2 in the baseline period, which is sustained for more than or equal to at least, again, as I discussed, 2 calendar days. Increase in the daily minimum PEEP values of more than or equal to 3 centimeters of water over the daily minimum PEEP in the baseline period, and which is sustained for greater than or equal to 2 calendar days. Then you've got infection-related ventilator-associated complication, which is referred to as IVAC. So if you've got a patient who's meeting the criteria for VAC or the ventilator-associated condition, then you take it further, and then on or after calendar day 3 of mechanical ventilation, or within 2 calendar days before or after onset of worsening oxygenation, now the patient has to meet 2 criteria, or both of the following criteria. That is temperature more than 38 or less than 36 degrees centigrade, or you've got a white cell count or leukocytosis, which is more than or equal to 12,000 or less than or equal to 4,000. Along with that, a new antimicrobial agent has been started and is continued for greater than or equal to 4 calendar days. But you've got VAC, ventilator-associated condition, which focuses on to IVAC or infection-related ventilator-associated complication. And then you talk in terms of a possible ventilator-associated pneumonia. So in that, you would be talking about purulent respiratory secretions. I think the slide is slightly small, but if you go through the references, CDC NHSN criteria, this would be available anywhere on the net. So it is defined as secretions from the lungs, bronchi, or trachea, which contains, first of all, you have to find out about the sample. It has to be a truly representative sample. It has to contain more than or equal to 25 neutrophils and less than or equal to 10 squamous epithelial cells per low power field. If the lab reports semi-quantitative results, they should be equivalent to above quantitative thresholds. Then along with that, you can have a positive culture, which has been collected by a qualitative, semi-quantitative, or a quantitative measure of sputum, ET, BAL, lung tissue, or PSB, or protected specimen brush. So it actually excludes the following. It excludes, Candida species or yeast. If you are even isolating them through the secretions, they are not recognized to be pathogenic. Cons or coagulase negative staph of species, not necessarily meant to be treated. Enterococcus, not meant to be treated. And normal respiratory or oral flora, not meant to be treated or acted upon. So then we come to a probable VAC, wherein you've got a patient. Now, so this is very clear. You've got a VAC, you've got an IVAC. After that, it's either a possible ventilator-associated pneumonia or a probable ventilator-associated pneumonia. So in this patient meets criteria for VAC and IVAC, and on or after calendar day 3 of mechanical ventilation, within 2 calendar days before or after the onset of worsening oxygenation, one of the following criteria is met. You've got pollutant secretions. Along with that, you've got a positive culture of ET. Threshold is more than or equal to 10 raised to power 5 colony forming units. Positive culture of BAL. The threshold is more than or equal to 10 raised to power 4 colony forming unit. Positive culture of lung tissue, again, more than or equal to 10 raised to power 4 colony forming unit per gram or equivalent semi-quantitative result. And again, PSB or protected specimen brush sample, which is got the least threshold, more than or equal to 10 raised to power 3 CFU per ml or equivalent semi-quantitative result. Along with that, you need to have one of the following. Positive pleural fluid culture, you have got to have a positive lung histopathology, you've got to have a positive diagnostic test for Legionella, you've got to have a positive diagnostic test on respiratory secretions for influenza, RSV, adenovirus, para-influenza, rhino, human metapneumovirus, and coronavirus. Again, this is where your multiplex PCRs come in nowadays. Now, once you've done the cultures, what do you do with those cultures? So, positive cultures which actually demonstrate pathogenic organisms who have improved on empiric therapy, obviously, and probably have VAP. Positive cultures which demonstrate pathogenic organisms who have not improved, but are still seeming likely to have VAP, with an explanation which can include either an initial inappropriate therapy or a complication of VAP in the form of abscess or empyema, or there is a coexistent second source of infection, which you should look for. If the patient has negative cultures and they have improved, they are unlikely to have VAP, assuming cultures were obtained prior to initiation of antimicrobial therapy, and then antimicrobial therapy should be discontinued. Patients who have negative cultures, who have not improved, may or may not have VAP, and further management actually should be individualized according to the suspicion for ventilator-associated pneumonia. So any other tests, a lot of people talk about ProCal, C-reactive protein, soluble triggering receptors, and CPIS scores, which are considered to be additional diagnostic tests. Now, please understand that CRP and ProCal, CRP is considered to be a poor man's procalcitonin, and they are though non-specific, but there are certain areas wherein they can be used. They are much more helpful in community-acquired pneumonia. And in terms of hospital-acquired pneumonia, their values and their guidance may mislead us. So they've got little role in suspected ventilator-associated pneumonia. Unlike a community-acquired pneumonia, PCT levels, of course, do not have a major role in a suspected ventilator-associated pneumonia. However, PCT levels can be useful in those patients with a confirmed ventilator-associated pneumonia when you want to take a decision to discontinue the antibiotic therapy, and it may be a useful prognostic marker. Biomarkers in bowel fluid have minimal diagnostic value. Now, then we talk in terms of CPIS scores, which were very, very relevant before. Very poor sensitivity and specificity. They've been ruled out in terms of their role in diagnosing VAP nowadays. Now, what about prevention, preventive measures? Obviously, non-invasive ventilation wherever feasible. Do not continue non-invasive ventilation if you feel that your patient requires an invasive ventilator. Avoid prolonged use of paralytic agents or IV sedation. Evaluate the need for transport out of ICU. Avoiding unnecessary reintubations, timely extubations, removing of nasogastric tubes as soon as possible, chest physios, elevating the head of the bed to more than or equal to 30 degrees, even though that has become a controversial measure now. No circuit changes, maintain adequate cuff pressures, careful drainage of tube condensates. Please go ahead and evaluate your need and use of stress ulcer prophylaxis, whether you really need it. Proper disinfection and using single-use products or devices may be helpful in terms of devising a preventive measures. Now, these are various preventive evidences in different papers. Now, fast hug and all these measures are quite general, and they have obviously come. I mean, when we talk about it, infection control, hand washing, early weaning, using NIV, stuffing, endotracheal tube aspirations in the form of a subglottic secretion aspiration tube, monitoring your cuff pressures, avoiding circuit changes, keeping patients semi-recumbents. These are all sort of tested measures. Pharmacological measures in the form of oral care with chlorhexidine, definitely yes. SDD, very controversial. Biofilm formation, there's no definitive formula, word on that about how to deal with it. Prophylactic antibiotic, again, very dubious role. Stress ulcer prophylaxis has a problem. Transfusion restriction, definitely preventive role. Glycemic control, yes. But giving patients break from sedations, yes. A short course of adequate antibiotics, yes, beneficial. And obviously maintaining enteral or post-pyloric nutrition would be better in these patients. So how to get a lead in cultures? Invasive methods, mini ball, bronchoscopic ball, or PSB with quantitative cultures are preferred over a non-invasive sampling, that is ET aspiration with non-quantitative cultures. Non-invasive sampling using ET aspiration with semi-quantitative cultures is a very acceptable alternative approach. And while this approach is less invasive, it actually tends to overdiagnose VAP. And a lot of people try to treat those cultures in isolation, leading to inappropriate use of antimicrobials. Now, lung biopsy is not actually routinely performed, but it is reserved for patients in whom infiltrates are progressive, despite using appropriate antibiotic therapy, or patients in whom you are actually suspecting a non-infectious etiology. Now, these are the various risk factors for MDR pathogens. This has been covered before. I'm not going to go through it again. Now, there are certain antibiotic specifics when we talk in terms. Most of the Indian ICUs previously were considered not to have risk factors for MRSA. But now, from Indian ICUs, there are a lot of studies which are coming out that are pegging the incidence of MRSA to as high as 60%, 60 in certain ICUs. So probably using MRSA empirically, maybe yes, it may need to be considered. And when we talk in terms of empiric use, these are the drugs which are recommended. I mean, this is a list I borrowed from ATS IDSA. When we look at it, we have such a high prevalence of VSBLs that probably only the last column, which talks about using carbapenems, is something that we should be looking at. Piperacillin tazobactam, again, dosing needs to be kept in mind. 4.5 grams IV every 6 hourly. Cefepime 2 grams IV every 8 hourly. Ceftazidime 2 grams IV every 8 hourly. Imipenem 500 mg IV every 6 hourly. Meropenem 1 gram IV every 8 hourly. Aztreonam 2 gram IV every 8 hourly. Plus you add maybe some aminoglycosides and fluoroquinolones. Plus, if you want to cover MRSA, you need to cover with vancomycin and linezolid. And the doses have been given, but lately I haven't seen much use of vancomycin and linezolid. People are, and Indian context, linezolid is getting more and more isolated for tuberculosis. Vancomycin, not a very great and effective drug. We're seeing the vancomycin creep coming in. So the other options, which I have not included here probably, for gram-positive, good options would be, among the newer options would be drugs such as levonoreploxacin, you will have arbicacin, you've got isopamycin. These are now MRSA-specific drugs, and probably teicoplanin, which has been a sort of a workhorse antibiotic for gram-positive infections. So these are the recommendations for dosing. Going through it again. This is how this has been formulated. I'm already spent some time on it. I'm not going to spend too much time on this slide. When we talk in terms of duration, there have been various papers, 5 days versus 8 days, 8 days versus 15 days. When we look at it, even a 5-day regimen for a ventilator-associated pneumonia has performed very nicely. So you don't need to add on too many days. But probably somewhere in the in-between range, in my ICU, probably what I would recommend is what we use, in fact, is a 7-day regimen with diagnosed VAPs. And this has done us well, not a major problem. So what about India? When we talk in terms of India, our problem is ESBL mainly. Prevalence is more than 90%. And we tend to use polymyxin B or E, polymyxin B or colistin. Polymyxin E is colistin along with carbapenems, sort of as our workhorse antibiotics. But the problems are that lung concentrations of polymyxins are quite poor. And along with that, there are concentration achieving dilemmas, concerns when we talk in terms of using colistin and what sort of dose we should talk about. And there has been a case on, supplementing IV dose with a nebulized colistin to be added in addition. The problem with adding nebulized colistin would be that after some time, you tend to get more bronchospasm in these patients and you tend to get new infiltrates on chest X-ray. So you are not sure whether it is because of the nebulized colistin or whether it is because of a new onset disease or a worsening of the disease. So that becomes a difficult one. You've got a newer kid off the block, ceftazidime avibactam, which is gradually, as far as Klebsiella is concerned, if you are able to do a Carba-R, then if you have an OXA48, then probably ceftazidime avibactam, along with, if you want to cover NDMs, estronam is becoming a favored combination gradually. And if you have an Acinetobacter baumannii infection, probably adding minocycline or doxycycline for better penetration makes a lot of sense. Very few take-home points as such. It seems very simple, but difficult, and a clinical diagnosis, significant mortality and morbidity. You have to have tailor-made antibiotic options, which are actually specific to your ICU, and keep the duration confined to maybe 5 to 8 days. Thank you.
Thank you so much, sir. Very elaborative talk and very nicely explained. Thank you so much. To the chairpersons, please.
Hello, Nikhilesh, sir.
Yes, ma'am.
Yeah, it was a very nice talk actually, and very, very informative. Yeah, some of the things I would like to ask that, sir, you have said that the 45% of the people are likely to get aspirate.
Correct.
So, yeah,
that is a fact we tend to ignore. I mean, we don't think of it as a normal phenomenon happening among people. So somewhere along the line, it gets missed out. Endotracheal tube, when we put in an endotracheal tube with cuff, it has been a classical teaching that probably the amount of aspiration that happens comes down because of the cuff lying there. But oropharyngeal secretion aspirations, they still tend to increase because it tends to stimulate it.
Okay, true, sir. And sir, the second question is that, is there any key difference between this VAC and VAE?
Previously, what was VAE has been now modified by CDC. So what I have done is I have borrowed it from CDC. This is how we sort of do a surveillance of our VAPs.
Okay, but is there any role of this clinical pulmonary infection score in differentiating both these things?
There are some papers that talk about it, but not proven anymore. I mean, it has not stood the time as far as evidence base is concerned. So CPIS score is now out. Previously, it used to be said if you got a score more than 6, probably you are very definitely sitting on pneumonia. But yes, what I would say is it is very good in terms of differentiating a pneumonia from a non-pneumonia. That is true, but it does not hold that true for a patient of VAP or a nosocomial pneumonia. So community, that's why we are confining its use now to community-acquired pneumonia.
Thank you, sir. Thank you.
Madam, any remark?
Very good talk, Nikhilesh. Very elaborately explained everything. One thing I would just like to emphasize more on is prevention of VAP. I mean, everybody is very understaffed in the ICU, and secondly, we don't have very trained staff. So it should be very essential that all these staffs who are dealing with ventilated patients, those dealing with patients who are on ventilator, they should be adequately trained to do good oral care, subglottic suctioning, and take good care of the hygiene, because that is how you are going to prevent it. So prevention is, I think, much better and more important than curing the thing.
No, I agree, ma'am. Actually, we do not spend that much time in prevention rather than treating it.
Yes.
VAP should come under as a preventive measure, but somehow we spend more time in treating it. And actually, when we look at the diagnostic criteria, they've only added to the confusion. That's what I feel. Sometimes the overlap is so close that it's very easy to reject probably a proper case of VAP.
Yes.
A good role of physiotherapy, nebulization, and repeated, if required, suctioning.
If you don't require, why you want to suction? I mean, I'll put it that way. Again and again, introduction of catheter again leads to problems.
Yes.
So any new thing getting introduced again and again repeatedly, that becomes a huge problem. It's just like Cotti only. You keep on, inserting more and more Foley's catheters, and it just keeps on staying in the system. So if not required, try to decrease those measures as quickly as you can. And this includes, I didn't include a slide on de-escalation, which uses to be my favorite, we should all know when to de-escalate our therapies as well. If it's not a VAP, that becomes very important.
Right, sir. Right, sir. But any other comments by the listeners,
So
by
this
the audience?
continuous subglottic secretion, is it practiced even now?
It is. I mean, evidence base has not rejected it. So I'll put it that way, that we haven't found any reason to sort of reject it till date. No major studies have said that. So probably yes. I do not know what future will hold. Maybe somebody comes out with a bigger paper, much more better quality study, which says that probably doesn't work, then probably we'll adopt that. But as of now, yes, what happened was that we used to stick by the gospel of keeping patients propped up at 30 degrees and all those things. And there was a fantastic, there's a fantastic studies in enteral nutritions, which have come out stating that actually you keep them flat or whether you keep them 30 degrees, it is not actually increasing the chances of aspiration. But what is happening is that by keeping them at 30 degrees, I don't know, some of them have even documented increased mucus production and increased secretion production. So that becomes a sort of a counterproductive thing.
Yes. And also now I think the focus is slowly changing from ventilator being the focus for VAP to, having a biofilm in the endotracheal tube and biofilm in the CVC catheter and, those kind of things for prevention of pneumonia.
That is true, ma'am. But what is happening is there's no magic bullet to it as
exactly. Yet. So I think it's a, what do you call, do you think it is a pharmacological company, what do you call, strategy or
do you think there is any
substance
that comes? As of now, yes, every product that comes into the market, they have to have some sort of USP to sell it. If they don't have a USP, how would they sell it?
No, all
so
these
I put it that way, but it has not been proven fully as yet that a particular product or a particular ET tube can counter biofilms absolutely or totally or in a very effective way, in a way to the extent that it would actually lead to decreased rates of VAP. So that becomes very difficult.
No, to justify something like silver impregnated CVCs, gold impregnated urinary catheter, all those biofilm and bio dressings, all these, they are slowly picking up in the market. I mean, they're selling, as you said, they're selling.
It will sell because, I mean, there would be some people, there would be few studies which would favor it. But the real problem that happens is with the critical care literature itself, what I would say is, sometimes we tend to tie ourselves in knots. Whether it is US, whether it is Europe or anybody, even good quality studies, even when they're coming from India, what really happens is that it is this sort of subset of patients is very, very difficult. Achieving a uniformity in terms of study purposes for among all these patients is very difficult. And, sort of introducing new major experimental therapies because these patients are compromised, because these patients are vulnerable, plus they require a lot of consent. So it becomes technically very difficult. So whatever evidence comes out of it, we tend to latch on to it. We do not know as of now how much of it becomes good quality, how much of it becomes low quality, and how much, I'll use the word implementable, how much implementable it is in our settings. So there are certain dilemmas, of course, I know, but I mean, we are not doing bad. If CDC has dilemmas, then we are fine.
And there is also something called cost effectiveness. Both.
Now, this is there, I put it this way, the way we look at it, even the preventive therapies have become quite costly with time.
Yes.
So how to find the balance, that becomes difficult. And I mean, a lot of people may find my comment slightly out of place, but we need to find a balance in terms of how best to use our therapies and how best to stratify their use. There may be some patients who may be not requiring that sort of things, and there may be certain patients who may be requiring all sorts of things.
I think you were bang on this because there's so much of misuse of antibiotics that, so probably, that's something.
I mean, what really happens is what I have seen is, I've been called to see many patients, and what really happens is, there's a group of people who have been watching a patient, who have been reviewing and addressing that patient. Sometimes the number of references may be 5 or 6. And actually everything was going fine with that patient. It's just that the patient is into a difficult weaning. There may be some atelectasis, some minimals are shadows and all those things. Patient may not be fully meeting the criteria of VAP. And then bingo, suddenly someone goes and gets a ET tube culture done. The moment the culture is done, 80 to 90% of these patients, something would be growing.
Yes.
And because they are in the hospital environment, most of the time they would be growing in MDR, XDR, or that sort of thing. So the next thing I know, the patient would be already on your carbapenem colistin combination, without actually realizing. And even if we want to diagnose that sort of thing, we need to go further. Now, probably, I know it's an expensive test, but now we need to look at carbars, because we have been using carbapenems and colistin and polymyxin B as our workhorse antibiotics, but probably we are wrong in that, in the sense that probably we may be using it for those patients for whom in actuality meropenem or imipenem MICs are say more than 8 or more than 16. So what we are giving is just expensive water, which may not be, sort of working on that bug at all. So that's where I said tailor-made antibiotic therapy. That's what we need to move up to.
And also the kind of bugs which are growing in that particular ICU specific to it.
Surveillance is
And
important.
over
but
the
again,
years,
surveillance
what
is
we have
costly.
seen is use of meropenem has gone up like water.
By the time government gets around to regulating its use, it would have lost its relevance. That's what I feel.
Sir, I think ESBL is on the roads nowadays.
True. I mean, I am acquiring, I've seen a lot of patients, asymptomatic patients in my ICU. We are seeing majority of them as NDMs still. And, but I've seen at least 30% overlap of NDMs with OXA48. It's those ones which are tricky, because those are the ones which require a clinician to understand that you can have 2 different types of Klebsiella growing in one single individual.
Yeah.
So you need to target both of them.
Both of them.
Till now, our thought process was that only one type of organism or one type of genotype of an organism can grow in a particular culture sample. It is no longer true. We are evolving, and so are they.
Yeah, and they have different sensitivity, different antibiotics at different MIC levels.
Yeah, so it becomes difficult to treat them.
Yeah. Sir, I have another question, maybe a little unrelated to this topic. We have so many antibiotics, say by the name of meropenem, we have hundreds of antibiotics available in the market. So what is your hospital practice? I mean, which antibiotics you choose? There is one can be available for say 5,000 and the other one is available for 300 rupees.
Correct.
So which antibiotic, I mean, which brand of antibiotics you tend to choose?
Oh, this is controversial. I won't endorse any brand from the society platform. That is one thing. What I would rather suggest you is that look at it this way. The problem lies with the CDRI and the way these people function. Actually, one thing probably trying to regulate the price of antibiotics once they become off patent by bringing them cheaper and cheaper has actually harmed the sort of ecosystem more rather than improving it. That's one thing. An initial thought process was that patients who had out-of-pocket expenses, they would actually do better. But at the same point in time, a prohibitive cost of an antibiotic also served as a deterrent for its prescription.
Yeah, of course.
Now, what has happened is that you've got branded ones, you've got generic ones. I make a difference. You've got branded generic ones, and you've got purely generic ones. Now, as per the Indian criteria, if I'm correct, and it was a few years back, somebody made me revisit that topic. Efficacy-wise, even if you are up to 75% of the innovator, you are actually allowed to go into mass production. But this can actually wreak havoc in those patients, say maybe who are having an MIC of more than 8 or something like MIC 8 to 16. So then it becomes very difficult. So what I do as a policy is if I'm going to use, I do not use purely generic brands, I use branded generics. This I can commit upon. And among branded generics, what I do is if I'm going to use, say, the innovator, say meropenem as 1 gram TDS, then branded generic, I would switch over to 1 gram QID. for the simple reason that I'm trying to factor in that 75%, 100% efficacy difference, which may be countered if I use a slightly higher dose.
Yeah.
As a matter of routine. But this is purely empirical, there's no evidence for this. This is purely what I practiced.
But I think, sir, in the rural India, the reverse is happening. The reverse is happening with people, because only of economic concerns they are using in the BD dose, and the higher antibiotic in BD dose. Okay, something is being used at least, but I think that is causing more damage to the ecosystem and to the this microorganisms sensitivity.
See, that's what I told you. We are running out of antibiotics, and the newer antibiotics are all going to be expensive.
Yeah, and there's no new antibiotic.
Yeah. So now the problem is that if you are government of India has suddenly woken up from last 2 years, and now they've decided that we should try to do something about regulating it. But they are not very rigid and serious about it. And that's what I meant when I said that by the time they have put in a regulatory mechanism which is foolproof in place, by that time we would have already stopped using meropenem and imipenem because they are no longer working.
Right.
Thank you very much, sir.
Thank you so much, sir. Thank you so much.
Thank you, Mike.
Thank you so much. Sir, with everybody's permission, may I end this webinar? Vishal, sir?
Sure, sir. Please, sir. Madam
Respected sponsor.
Indrani, ma'am.
Yes, yes.
Thank you, Mike.
Indrani, madam?
Thank you, Indrani, ma'am. Thank you.
Sure. Excellent. Yeah.
Thank you, everyone.
Thank you very
good interaction, and we learned a lot from this.
Really enjoyed. Yeah.
Thank you so much. Thank you so much.
Thank you so much.
Thank you so much from the bottom of the heart, from the Indore City branch, for having a very patient listening to all the chairpersons as well as the speakers. And thank you so much, respected Indrani madam, respected Kaul sir, respected Malhotra sir, and Mr. Vishal sir. As usual, very dynamic, and thank you so much for the backend support, Vishal sir.
Thank you, sir.
All speakers, as well as to all the chairpersons for making this webinar really successful.
Thank you so
Thank
much.
you.
Thank you.
Long live RSACP.
Thank you. Good night.
Thank you.
Good night,
Good night.
everyone.
Vishal.
Yes, sir.
Vishal, I'm trying to get Rujuta Divekar to give a presentation for RSACP. You've heard about Rujuta Divekar, right?
Madam nutritionist.
Nutrition, yes. Vishal. Yeah, I'll just speak to you 1 minute. Page call, sir. Sir. Call, sir.
I said very brilliant idea. Very brilliant idea.
I'm just trying. I hope to be successful. She's responded, but let's hope that she comes out. If she does, it will be a big thing for us.
Excellent.
So
Great.
I'm just trying, sir.
Great, ma'am.
Thank you all very much. This was a fantastic learning experience for all of us. Thank you very much, Mayank. It was
Thank you so much, ma'am.
really,
But I really apologize for no attendance. I really apologize for no.
I don't blame you for that. I don't blame you, because there are so many webinars, so many of them. I mean, people are sick and tired of attending. So I don't blame you. Those who want to attend, they will attend anyway.
Right.
So, and we are happy that people are attending. That's important.
But the show has to go on. But the show has to go on.
Very true. Very true. The society has this responsibility of spreading education, and we will continue to do that.
I hope it was a successful webinar in terms of academics.
Fantastic.
Yes, definitely.
It was a big learning experience,
Right.
and we thoroughly enjoyed the
Audience doesn't matter, ma'am.
No.
Thank you so much, Hira.
For Dr. Mayank, I'm just letting you know that people are not attending because they have an overdose of webinars. That is the problem. It's not your fault at all.
Right.
Not your fault.
Right. Thank you so much, ma'am, for
Thank you
encouraging.
so much.
Thank you. Thank you. Long live RSS.
Long
Long
live
live
RSS.
RSACP. Long live RSACP.
Long live ISC. Yeah.